Hello, everyone. This is Dr. Madhusudan Rao and the program I teach medical students. The topic of today's lesson is Pontine stroke. Introduction. Stroke is one of the leading causes of morbidity and mortality in the world. Pontine stroke is in particular, are more catastrophic. Okay. Presentation of Pontine stroke is variable. It could be as classical crossed hemiplegia with ipsilateral clearing palsy and contralateral hemiplegia. Okay. It may also present as isolated contralateral hemiplegia or pure sensory stroke. Presentation is primarily determined by the anatomical boundaries of the area of the infarct and the blood vessel involved. Well, many of the stroke events are preventable with proper care. Coming to anatomical considerations, pons is the largest part of the brainstem, as you know. It is connected rostrally with the midbrain and caudally with the medulla. Well, it has got connections with the cerebral hemisphere, cerebellum, and spinal cord. Well, it receives its blood supply from the paramedian and perforating branches of the basilar artery and the circumference branches. Basilar artery is formed by the merging of the two vertebral arteries at the pontomedullary junction, and it terminates at the posterior cerebral arteries at the rostral end of the pons. In its way, it gives the paramedian and perforating branches and the circumference branches to supply the pons. Well, besides this, other sources of blood supply to the pons include the anterior inferior cerebellar artery and superior cerebellar arteries. Pons connects the brain with the cerebellum and the cerebellum by the peduncles. That is, you have got the superior, middle, and inferior peduncles. It is supplied by the superior cerebellar artery, basilar artery, and inferior cerebellar artery. Well, in its parts, it is described as the dorsal part as the tegmentum, ventral part as the basis pons. Tegmentum houses the nuclei of the cranial nerves, that is the trigeminal, abscens, facial, and vestibulocochlear. It also houses the long tracts, that is medial longitudinal fasciculus, medial lemniscus, spinothalamic, and lateral lemniscus. These long tracts, they pass through the tegmentum of the pons. Ventral part is described as the basis pons. It houses the corticobulbar, corticopontine, and corticospinal fibers. Coming to the etiology of the Pontine stroke, the most common cause of Pontine infarct is the small artery disease. Okay, less common causes include large vessel disease due to atherosclerosis. Sometimes atherosclerosis of the vertebral arteries may cause embolization of the small perforating branches in the posterior cranial fossa. Well, other causes of ischemic stroke is cardiogenic emboli. There are some established risk factors which include hypertension and diabetes, lipohydrosis involving the small blood vessels, and other risk factors include smoking, hypercholesterolemia, hypercoagulable states, and vasculitis. But the studies are lacking to prove these risk factors in the cause of Pontine stroke. Well, other risk factors, elderly with chronic hypertension is a risk factor, and diabetes, dyslipidemia, and heart diseases. Young people are also liable, susceptible for the Pontine stroke. When there is a risk factor like hypercoagulable state, the autosomal dominant cerebral arteriopathy, and vertebral artery dissection, are some of the factors where the young people are affected by the Pontine stroke. Coming to epidemiology. Studies are lacking with regard to the prevalence of the Pontine infarcts. Pontine infarcts will generally occur as a part of the large posterior circulation strokes. Okay. The clinical presentation depends on the area involved, out of which the anterior medial and anterior lateral regions supplied by the basilar artery is the most common one of common type of Pontine stroke. That is, anterior medial and anterior lateral regions supplied by the basilar artery is the most common type of Pontine stroke, which is followed by lateral region supplied by the basilar and anterior inferior cerebellar artery. Okay. Then the other type is the posterior or dorsal region supplied by the superior cerebellar artery. Okay. These are the order of commonness with regard to the Pontine stroke. Most common thing being anterior medial and anterior lateral region supplied by the basilar artery. Okay. The lateral infarct supplied by the anterior inferior cerebellar artery, followed by posterior supplied by the superior cerebellar artery. By and large, studies examining the Pontine stroke are exclusively lacking. This is one difficulty to make a statement with regard to the epidemiology of Pontine stroke. Coming to the clinical presentation, it depends upon the anatomical area affected. Okay, based on the area affected, it is classified into ventrocaudal, mid-Pontine, tegmental Pontine syndrome, multiple Pontine infarcts, bilateral Pontine infarcts. Okay, so let us touch one by one with regard to the clinical presentation. Coming to ventrocaudal Pontine infarcts. Okay, here lesion involves the paramedian perforating branches of the basilar artery. Okay, basilar artery, after being found by the merging of the two occipital artery, it runs in the midline of the pons ventrally. Okay, it gives away the paramedian and perforating branches to supply the pons. It presents with the contralateral hemiparesis or hemiplegia, bilateral facial palsy due to involvement of the facial nerve nucleus. Injury to the sixth nerve fibers results in ipsilateral rectus palsy. Okay, it affects the nucleus of the facial nerve and the emerging fibers of the sixth nerve because they run in close proximity with the facial nerve nucleus. Then lateral spinothalamic tract involvement in the infarct results in the contralateral loss of pain and temperature sensation. Okay, lateral spinothalamic tract takes the pain and temperature modalities. And well, the clinical features can be grouped into Millard-Gobler, Fowley syndrome, and Raymond syndrome. So we try to touch these things. The total clinical manifestations can be grouped into Millard-Gobler, Fowley's, and Raymond syndrome. What is Raymond syndrome? It is characterized by unilateral ventromedial pons infarct. It involves pyramidal fibers and fascicles of the abscess now, so thereby causing contralateral hemiparesis with ipsilateral abscess per se. Millard-Gobler involves the fascicles of the abscess and facial nerve in the medial ventral pons, okay, thereby resulting in the contralateral spastic hemiplegia with ipsilateral abscess and facial nerve facial palsy on the side of the lesion. Fowley's is a little more extensive lesion caused by infarcts of the pons involving corticospinal tract, facial and abscess nerve fibers, and PPRF, medial longitudinal fasciculus, and medial lemniscus. Presence with ipsilateral fascial palsy, ipsilateral absence palsy, and ipsilateral lateral gaze palsy, and contralateral hemiplegia and hemianesthesia. Coming to next group, that is mid-Pontine base infarct syndrome. This is caused by obstruction to the blood flow in paramedian branches of the basilar artery and obstruction to the short circumference branches of the basilar artery. The extent of the area affected determines the clinical presentation. The clinical features include ipsilateral ataxia, okay, dysarthria, ipsilateral sensory loss on the face due to infarct of the sensory nucleus of the trigeminal nerve. Okay. Lateral infarcts may result in the contralateral hemiplegia. There could be a combination of symptoms of hemiparesis, ataxia, dysarthria, dysmetric syndrome, clumsy hand syndrome with weakness of the hand with dexterity failure. Okay. Next one is the tegmental-Pontine syndrome. Because Pontine tegment, as we touched the anatomy, contains the nuclei of the cranial nerve, that is trigeminal, absence, facial, and vestibulocochlear. It also houses the medial longitudinal fasciculus, medial lemniscus, Pontine reticular formation, and most important thing is it houses the respiratory center. Blood supply in the anterior inferior cerebellar and superior cerebellar arteries affects the causing rostral Pontine syndrome. Okay. Blood flow in the anterior inferior cerebellar artery and superior cerebellar arteries, if it is affected, it results in the rostral Pontine syndrome. Characterized by ipsilateral sensory loss, that is due to the involvement of the fifth nerve, sensory nucleus, and contralateral hemisensory loss because of involvement of the medial lemniscus and lateral spinothalamic tracts. Okay. Ipsilateral hemiataxia because of involvement of superior cerebral peduncle. Caudal Pontine syndrome is due to impaired blood flow in the short circumferential arteries and anterior inferior cerebellar artery. It presents with the hemiataxia due to involvement of inferior cerebellar peduncle. Okay. Due to the involvement of the corticospinal fibers and medial lemniscus, results in ipsilateral horizontal gaze paralysis, ipsilateral sixth nerve palsy, and contralateral hemiplegia and hemianesthesia. This is due to the corticospinal fibers involvement and medial lemniscus. Okay, that results in the contralateral hemiplegia and hemianesthesia. There is ipsilateral horizontal gaze paralysis with the ipsilateral sixth nerve palsy. Because the tegmentum for the brain contains all the cranial nerve nuclei. Coming to next syndrome, that is multiple Pontine infarcts. Presence with pseudobulbar palsy due to involvement of the corticobulbar fibers. Okay. Corticobulbar fibers runs from the nerve cells of both the hemisphere, motor areas of both the hemispheres, and to supply the motor nuclei of the cranial nerves located in the brainstem. So this is the supranuclear paralysis with regard to the motor cranial nerves. That results in the severe dysphagia and dysarthria because of the increases spasticity of the muscles of oropharynx. Okay. Perforating arteries territories are affected in this particular infarcts. Some patients may present with uncontrolled pathological laughing and crying. This is one of the characteristic features of multiple Pontine infarcts. Look at this picture. It is a cross section of the level of pons showing the cranial nerve nuclei. If you look into that, motor cranial nerves are located more medially when compared to the sensory cranial nerves, which are located at dorso ventral part or dorsolateral part. Okay, this is the abscess nerve nucleus located more at the floor of the fourth ventricle. That is more dorsally and towards the midline. It is located at the fourth floor of the fourth ventricle. The nucleus is looped by the fibers of the facial nerve. So when there is absence nerve, nucleus is affected, the fibers of the facial nerve are involved. Okay. Well, these are the medial fibers of the medial lemniscus that carry the sensory modalities from the spine, from the periphery, from the spinal cord, as the spinal thalamic tract that run in the medial lemniscus. Well, more ventral medial you find the pyramidal tract, and the fascicles of the sixth nerve pass close to the pyramidal fibers. So infarcts involving this area results in the involvement of the sixth nerve nucleus with contralateral spastic hemiplegia, the characteristic feature of Raynaud syndrome. This picture again shows this is the ventral part, this is the dorsal part, this is the tegmentum containing the cranial nerve nuclei. This is the fifth cranial nerve nuclei. Well, this is the medial lemniscus. This is the trigeminal lemniscus, etc. Okay. Next syndrome is the bilateral Pontine infarct. Okay. This results in locked-in syndrome. Bilateral Pontine infarct results in the weakness of all four limbs with spasticity. Infarct of the ventral middle pons involving the bilateral corticospinal fibers, corticobulbar fibers, and corticopontine fibers. It is associated with the loss of voluntary movements of all four limbs, that is resulting in tetraplegia. Patient is unable to speak. There is bilateral facial and absence of palsies, horizontal gaze paralysis, but oculomotor nerve is intact. There is respiratory failure. Patient is conscious. Cognitive function is intact. Okay. You will observe sometimes stereotypes, episodes of dysarthria, motor and sensory disturbances, and ophthalmoplegia, which is recently described as the Pontine warning syndrome. Pontine warning syndrome is characterized by stereotyped episodic dysarthria, motor and sensory disturbances, and ophthalmoplegia. Okay, this is prescribed as the Pontine warning syndrome because this syndrome may progress into bilateral Pontine infarct when left unrecognized and untreated. That's why it is described as the Pontine warning syndrome. So, well, that concludes the clinical presentation of the various infarcts involving the Pontine stroke. To sum up, the distinguishing feature that can be used to identify the anatomical location of the Pontine infarcts are as follows. Number one, contralateral hemiplegia with internuclear ophthalmoplegia and horizontal gaze paralysis. Remember, contralateral hemiplegia, internuclear ophthalmoplegia, and horizontal gaze paralysis is due to medial Pontine infarcts. Okay, remember this. Contralateral hemisensory loss and ataxia. denotes lateral infarcts. The last one is ipsilateral lower motor neuron type of facial palsy, ipsilateral absence nerve palsy, and ipsilateral sensorineural deafness and vertigo indicates caudal pontine infarcts. So in caudal part of the pons, you have got the eighth nerve nucleus, got the absence nerve fibers, and facial nerve fibers. So it results in the ipsilateral lower motor neuron type of facial palsy, ipsilateral absence nerve palsy, and ipsilateral sensorineural deafness and vertigo. These are the features of caudal pontine infarcts. Coming to the evaluation, it is very important to record the vital data. Record the respiratory rate, record the blood pressure, okay? Stabilize hemodynamically, attending to the airway, breathing, and circulation. After doing this, go for the complete history and complete clinical examination of the nervous system. Look for the cranial nerve palsy, look into the sensorium and the other status of the sensorium of the patient. Okay, if he is conscious, test the higher intellectual functions and examine all the cranial nerves, right? Examine the motor system, test for the coordination, and look for the gait abnormalities, etc. Then proceed for imaging. CT at the brain will tell you about the hemorrhagic stroke and site of hemorrhage. MRI brain is diagnostic for ischemic stroke in order to identify the area of infarcts. Then start early treatment. Because the potential for the complete recovery of the stroke drastically diminishes with the loss of every minute to initiate the treatment. Okay, you should not left the stroke untreated. The goal is reverse the extent of ischemic injury that is adjusted into the infarct. Number two, prevent complications. Then lastly, facilitate early improvement of functional capacity. These are the goals of management in a patient with stroke. Coming to the lines of treatment. So after stabilizing and taking the MRI and other evaluation or imaging studies, if you think it is a case of obstructive stroke, go ahead with the alteplase as a thrombolytic agent and treat hypertension. And also you can do the mechanical thrombectomy in certain other cases. Continue antiplatelet therapy with the clopidogrel and aspirin. And continue anti-lipid treatment with heavy dose of statins. And not but the least, lifestyle management. Treat diabetes, avoid smoking, regular exercises, and nutritive diet. And let the patient be trained with the yoga and other meditations to improve the functional ability of the paralyzed limbs. Thank you very much for patient listening. I'll meet you again in the next class. Until that time, bye-bye.